Good evening. This is a case study review on gastric cancer and a patient case presentation um, 24. So this case is case 24 for gastric cancer. The patient presented as a 62-year-old Latino male presenting with complaints of persistent weakness, fatigue, and low energy. Over the past 3 weeks, his heartburn is getting worse, even with his normal treatment, his GERD medications. A stool sample was done and it tested positive for occult blood, raising concern for a gastrointestinal bleed of some kind. He has past medical history of benign prostatic hyperplasia, asthma, and GERD. He smokes a pack and a half a day of cigarettes and drinks 3 to 4 glasses of brandy a day as well. So his diet consists of processed meats such as hamburger, hot dogs, and he does not eat any fruits according to him or vegetables or whole grains. And he told us he lives a sedentary lifestyle. He does walk occasionally. His current medications are omeprazole for his GERD, ipratropium for his asthma or possibly beginnings of COPD, albuterol as needed, um, triamcinolone for asthma, and terazosin for his prostate. Further investigation is needed given his positive occult blood and his symptoms and lifestyle choices. So the gastric adenocarcinoma is the most common type of gastric cancer, accounting for over 90% of all malignant tumors coming from the stomach's mucosal lining. So globally, it remains a public health burden. According to the recent international cancer statistics, gastric cancer results in nearly 1 million new diagnoses each year and over 770,000 deaths, making it one of the leading causes of cancer related mortality worldwide. Even though the incidence has gradually declined in some regions, there is a distinct geographical pattern. So, Eastern Asian countries such as Japan, South Korea, and Mongolia continue to experience the highest rates. In contrast to Western countries like the US, we are now seeing an increase in tumors located in the proximal or upper portion of the stomach. So, this is where you see the tumor later in our patient. There are many risk factors that can contribute to gastric adenocarcinoma. One of the most significant is chronic Helicobacter pylori or H. pylori infection, which leads to long-term mucosal inflammation and cellular changes. So lifestyle factors that play a role, well, a major role, are the easiest to change. So tobacco use, heavy alcohol, diets rich in high salt and processed meats, and low intake of fresh food, fruits and vegetables all increase the risk of development. Obesity, low socioeconomic status, and certain occupational exposures have also been associated with higher incidences of the gastric adenocarcinoma. A challenge we face as providers concerning gastric cancer is it often presents with very vague symptoms. So early on in the disease, it's normally either asymptomatic or accompanied by vague symptoms such as indigestion, mild epigastric discomfort, or fatigue. As a result, the majority of cases are diagnosed at more advanced stages. This increases the high mortality rate due to the difficulty in diagnosis. So the symptoms of that are often again presented, as we stated before, are indigestion, mild epigastric discomfort, and fatigue, and so they are associated with many other disorders. So the late presentation in our patient symptoms of progressive fatigue, worsening heartburn, and positive occult blood are leading to this diagnosis. So the pathophysiology at the cellular level. So gastric adenocarcinoma develops through a well-characterized sequence of cellular changes driven primarily by chronic inflammation. So in most cases, this begins with an H. pylori infection. So over years or even decades, H. pylori induces chronic active gastritis, which progresses into atrophic gastritis and then to intestinal metaplasia, dysplasia, and ultimately carcinoma. The stepwise chorea cascade remains the dominant model of carcinogenesis. So CAG-A cytotoxin-related gene A, is a protein that is a very important part of the pathogenicity of H. pylori. H. pylori produces VAC-A, which is vacuolating cytotoxin A, which is a toxin linked to peptic ulcers. So these proteins enter gastric epithelial cells and alter signaling pathways that regulate apoptosis, and inflammation. So the CAG-A activates oncogenic pathways, for example, but not limited to STAT3, which is signal transducer and activator transcription 3. It promotes uncontrolled cell growth, inhibits normal cell death, and creates a pro-inflammatory environment that would support tumor formation. So another key mechanism is the production of reactive oxygen species during chronic inflammation. So persistent oxidative stress causes direct DNA damage. There is repeated injury over time, which is combined with DNA repair mechanism, leads to genomic instability, a hallmark feature of gastric cancer development. So the liver is often a common site for metastases due to the stomach draining into the portal venous system. So when looking at all of our clinical manifestations after reading the pathophysiology, they reflect the suspicion of gastric cancer. So chronic blood loss, nutritional deficiency, metastatic spread are all indicative of the diagnosis. He presented with persistent weakness, fatigue, and low energy, which could have been seen as just another iron deficiency, and poor diet combined with asthma and possible beginnings of COPD, given his smoking habit. The provider could have only looked that far. However, in this case, more tests were done and it was important in the end. So the occult blood in his stool and worsening heartburn despite taking his omeprazole suggested mucosal irritation and possibly pointing to tumor growth. So this often presents with involvement of the upper stomach and presents as reflux that no longer responds to GERD therapy, which was happening in this case. So his lifestyle history significantly contributed to the cancer development. Long-term heavy smoking, daily alcohol consumption, and a diet dominated by processed meats with almost no fruits, vegetables, increased gastric mucosal inflammation, and carcinogenic exposure. So when you add the chronic H. pylori infection, the risk becomes even more significant as it was confirmed by positive antibody testing. So objectively, he has pale conjunctiva and koilonechia, which is spooning of the fingernails. I probably butchered that, even though I listened to the pronunciation of it. Support the small size red blood cells in iron deficiency anemia. So laboratory findings further confirm this: low ferritin, low iron, low TIBC, and an MCV of 70. So clubbing and edema may be related to chronic hypoxia, nutritional compromise, or systemic effects from the metastatic disease. So his elevated AST and ALT and bilirubin are concerning for hepatic involvement, which the CT later confirmed with multiple liver lesions. Endoscopy revealed a 5 by 3 centimeter mass in the upper stomach, and the biopsy confirmed adenocarcinoma. The endoscopic ultrasound showed tumor presentation through a gastric wall and CT evidence of liver metastases, indicating stage 4 of the disease. With all this information, the patient's clinical picture aligns with the advanced gastric cancer presenting with chronic blood loss and anemia and metastatic spread. So at this point, once we have all the diagnostics and everything, education needs to be about small changes in lifestyle that can help this patient be more comfortable and help him with new treatments he will be introduced to. So as the APRN, we will have the unique role of spending time at his bedside and with the patient and his family to navigate this new diagnosis. So this is a critical role in providing holistic care that extends beyond the physical symptoms. Through a Christian worldview, the APRN approaches the patient as a whole person, body, mind, and spirit. This means caring with compassion, offering presence, and maintaining the patient's dignity during a difficult diagnosis, such as this gastric cancer. With education on a new diagnosis, treatment options, the APRN will help facilitate informed decision making. So every step along the way, it can be explained to the patient and family to help them make the best choices for their family and how the changes will affect them. So because this patient has several modifiable lifestyle factors such as smoking, alcohol use, and poor nutrition, the APRN can also guide him towards healthier behaviors. This, however, has to be done in a non-judgmental way with a supportive attitude. So compliance will be higher with positive approach. If the patient is open to spiritual care, then the APRN can offer prayer and guidance in the area of offering a chaplain or religious leader to help them with the new diagnosis. In this framework, the APRN advocates for symptom relief, emotional support, and compassionate presence as the patient navigates advanced illness. A cancer diagnosis, it does come with many fears, and it's helpful as a provider to offer as much education and resources as possible and help them have a realistic view on the informed choices that they are making. So, as you think about these questions, cancer is such a life altering diagnosis for a patient. It is imperative as the APRN to care and the care team to really consider how they interact with this patient and family. We cannot change the things that he's already done to his body and the things that have already happened, but we can sit with him and them in all of the emotion and the work with them to make the outcome better. Comfort and caring and looking at the whole picture will make a difference in how they handle the treatment, side effects, and the progression of the disease. So these are just some thought-provoking questions. Do you think changing a lifestyle behaviors at this point after a diagnosis will offer change or help in this case? So those are things we just have to consider. Like how much can we ask him to change that's really going to make a difference or make him more uncomfortable or what's really going to work best for him? So, how do the diagnostic findings determine the staging of the prognosis in the gastric cancer? And then, as the APRN, how can we prioritize the interventions for caring for this patient with gastric cancer? So, thank you for listening, and these are all my references.